Very good evening to all. So today we are here to discuss about the INICET 2024 recall questions. I'm Dr. Monisha Arulalan from MS OBG from JIPMA. So overall, coming to our exam, how was the exam? The questions are the same topics, repeat topics, and yes, once at the first glance it will be like it's the easiest exam, but the options were twisted in these exams because there were two close answers, and that was the whole concept of this exam this time. Coming to the previous questions, yes, they have repeated the same topics. To be very clear, they have repeated the same topics, but in a twisted format. They've asked the options. But considering OBG is little easier, as I felt. I don't know about how you people have written it, but OBG, if I have to say, it is. I have to say they touched upon the basics and a very anticipated questions and previously asked questions. If you, I think OBG was little better than other subjects. Now we'll get back to our recall. So we're starting with the first question. An 18-year-old female with amenorrhea complains of urinary retention. Suprapubic bulge and bluish bulge is seen on a physical examination. What is this condition the female has? I think this question we have solved it many number of times in our exams, mock exams, and anybody would have been able to answer who have written the exams, mock test, everything. Definitely they would have given the correct answer. It's a very straightforward answer, and this is an typical case description for an imperforate hymen. So imperforate hymen we have discussed, as we have discussed with the mock papers. You can see imperforate hymen. They, as a case scenario, we have discussed even as a image-based questions. So here they've asked us a simple case scenario presenting with primary amenorrhea with a normal sexual characteristics with a cyclical abdominal pain, which is a characteristic of the imperforate hymen, hematocolpus, hematometra, and hematosalpinx to be remembered. And what other things to remember on physical examination? Yes, definitely this is what they've asked in your exam. Bulging or bluish hymenal membrane or a blind end pouch on examination. This is what the image that usually to remember I give them, so that always image-based questions retains a lot. I think with this image at least they would have remembered what is the condition. Diagnosis you do with an clinical as well as with ultrasound and confirm it with an MRI if you want to. Rarely associated with the urological abnormality. This is also always asked a question whether it's an association with any urological abnormalities. It is very rarely associated, and treatment is giving a cruciate incision, or you can do a sterile puncture or a single dose of prophylactic antibiotic and estrogen cream to be applied on this incision, mainly for the hymenal ring to prevent it re-epithelialization. So this is a very simple, straightforward. So I started with a straight question. Easy question. And what is the use of discussing this? It is the same thing. The concept applies even for your NEET exams. Don't hurry up seeing a question. Yes, you have seen a simple question. You know that question. Please don't jump your answers. Please wait and read properly what is given in your question. See your options, because don't always think if they're asking us some questions, you will have a straightforward. Some questions are little twisted. So you have to anticipate a twist in every question and then answer your paper. You scored better with this. So anticipate. If you see a very familiar or a very frequently asked question, they will definitely have a twist. But in this question, there was not much to twist in this because it's a very straightforward question. I think everybody would have got this right. Now coming to a next question. Next question is a pregnant woman at 36 weeks of gestation with chronic hypertension. She's a chronic hypertensive pregnant woman. Okay? She's 36 weeks. So that is what you notice first thing. chronic hypertensive patient at 36 weeks. She complains of headache and visual disturbance. When I say the patient with already, whether she is gestational hypertension, chronic hypertension, preeclampsia, if they present with headache or visual disturbance, she is showing all the imminent symptoms for an eclampsia. Okay. So it's a straightforward. Even if I have to say, even she is at 34 weeks, even she is at whatever period of gestation, your answer should contain magnesium sulfate. With that itself, you will land into option 3. And next, whether at what time, whether you have to terminate or not, that depends on your period of gestation. That is at 36 weeks is your period of gestation. So you have to deliver them. So here is a very clear-cut option that you have to remember is option C. It is IV labetalol giving sulfate. So this was our discussion about hypertensive disorders in pregnancy. I think we have thoroughly understood the different types of hypertensive disorders in pregnancy. That was the first thing that you have to remember for solving any type of questions. And understanding what is said to be a severe or a non-severe preeclampsia, that is also a very anticipated question. And this was a very straightforward question. Any patient, whether she is a gestational or preeclampsia, severe or non-severe, going for a chronic hypertension, developing an imminent symptom is an indication to terminate, especially in the question they have mentioned 36 weeks. That you're not going to do anything, so you have to terminate the pregnancy, and very promptly you have to give the magnesium sulfate. That becomes the most important thing that to be seen in your option. Okay. This was a very easy question. Yes, hypertensive is a very, very important topic in considering in that of an INICET. It's a very, very important topic. They ask very complicated questions from hypertension disorders, but this time it was relatively very easier. They always touch upon the pathogenesis and the preventive measures for a preeclampsia. Yes, last year's paper was a little complicated, always pointing towards the magnesium sulfate and pathogenesis. But this time they've asked a very simple case scenario that I think everybody would have also right. Now coming to the next question. A 26-year-old lady presented to the clinic with high risk for neural tube defect. A quadruple test screening report. On a quadruple test screening report and low risk for trisomy 21 and 18, what is your next step of advice for this patient? Yes, this type of question was very much anticipated in this INICET. Screening in pregnancy is a very important component, and definitely in upcoming exams also. Screening for aneuploidy. Screening for aneuploidy is going to be a very important topic in very upcoming all the exams, even for your NEET exams and for your further INICET exams. So one such questions, but this was very simpler form of asking screening in pregnancy. See, quadruple test is a part of your second trimester screening, which showed a high risk for a neural tube defect, but a low risk for the other trisomies of 21, 18. So here it's a very clear cut. So you have a quadruple report. So this was just a dummy report I'm just showing you here. See, quadruple reports, they interpret, this is how you get a quadruple report, where they analyze for the alpha fetoprotein, the estradiol levels, HCG levels, as well as the inhibin levels. This comprises of that of a quadruple report. Okay. So finally, they give a report for a Brown syndrome, that is trisomy 21, trisomy 18, and they also give a report for a neural tube. Here they have given as open spina bifida, but usually all the labs follow it as giving a risk for the neural tube defect. Okay. So the question is very clear cut. So the quadruple report showed that was the increased risk for NTD. and there is a low risk for trisomy 21, trisomy 18. What is your further step? If the question, now we'll start with your neural tube defect itself. So it's a neural tube defect. Neural tube defect is one abnormality that you can identify with your ultrasound itself. Unlike that of a trisomy 21 and 18, yes, you do have a soft markers even for a trisomy 21 and trisomy 18, which you cannot say 100% that the baby is affected by just doing an ultrasound. So it is always important that we prove even by doing the by a confirmatory test, either by an amniocentesis or a chorionic villus sampling, even if you have a soft marker that is pertaining to trisomy 21 or 18. But neural tube defects are not like that. Neural tube defects are the things. What are the neural tube defects? Anencephaly, spina bifida. Okay. All these things are definitely seen through the ultrasound. You can diagnose by ultrasound. Okay. So this ultrasound becomes the most important. That is, we are able to see, and you can definitely say, yes, there is a neural tube defect in the fetus. Okay. And now the question comes. What is the next step advice for this patient? So you do a quadruple test. Around 16 to 20 weeks is the time you do a quadruple test. So anytime around this, she has done a quadruple test, it showed an increased risk of NTD. What will you advise her further? Will you do her a chorionic villus sampling? Definitely this becomes a no. Why do you say it's a no? Because when you do a chorionic villus sampling, it is done between 10 to 13 weeks. Okay. Maximum you can do up to 14 weeks. So definitely this option is ruled out. When she has done a quadruple, that means this option is ruled out. Even if you have not known anything of this was a simple way to approach. Okay. Next, doing an amniocentesis or doing an NIPT or an anomaly scan. If the question was there was a high risk for trisomy 21 or trisomy 18, okay, if the question was in a different way, saying there was a high risk for trisomy 21, my answer would have been cell-free DNA testing. That is, you can do an NIPT. Okay. If you have a soft markers in your ultrasound pertaining to trisomy 21, then you do an amniocentesis to confirm it. But here the question lies is there is a high risk for an NTD. NTD is a one entity that you can see by ultrasound. So what should be my answer? It should be your anomaly scan. That is called the TIFA scan, or it's also called the level 2 scan. That should be your answer for this question. The same question, if they ask if there is an increased risk, they ask if there is an increased risk for trisomy 21. If they ask the same question as increased risk for trisomy 21, the whole scenario changes. Okay. So that's how you answer your question. Since it is a neural tube defect, it's a neural tube defect that we can easily identify by an ultrasound and give a confirmatory diagnosis. Yes, the fetus is with an encephaly or a spina bifida. Okay, or any other type of neural tube defects that you encounter. This was again an easy question. Of course, coming to a very next question is your antenatal corticosteroids. Oxytocin, antenatal corticosteroids, these are the two things that you should not be forgetting at all. And they've asked of all, they can ask antenatal corticosteroid. Yes, antenatal corticosteroid, they can ask any number of questions. So there are a lot of new changes in this, but they've asked a very simplest form from that antenatal corticosteroid correct dose. We have answered this n number of times, and we have solved in our questions also. So betamethasone 12 milligram, IM2 doses 24 hours apart, but the dexamethasone 6 milligram, 4 doses 12 hours apart. These are the two antenatal corticosteroids that we give. So that is what they've asked, which is a correct dose. I think definitely everybody would have got this right answer. It is dexamethasone 6 milligram 12 hourly, 4 doses is your answer. Okay. And what else you can expect from antenatal corticosteroids? I always keep telling what is the timing? They can be the important question. Timing, that is 24 weeks to 33 plus 6 weeks. Next is about the neonatal benefits. It decreases the frequency and severity of the respiratory distress, intracranial hemorrhage, necrotizing enterocolitis, and death. What is about the effect of giving to a fetal and maternal effects of giving an antenatal corticosteroid? One is a transient reduction in the fetal breathing and body movement sufficient to affect the interpretation of a biophysical profile. There is a transient rise in the maternal platelets and WBC. Maternal WBC in excess of 20,000 rarely due to steroid. Challenged maternal glucose tolerance as well as women may require an insulin resistance and to maintain a euglycemia. So definitely you can anticipate questions from this in your future exams. So antenatal corticosteroids as well as oxytocin. You have to know in and out of this drug, everything about this drug. So please revise this also for your NEET exam. Okay. Coming to the dosing and frequency, please remember administration of a single course of corticosteroid before 33 weeks of gestation improves on neonatal outcome. See, very standard is if the patient is imminent for delivery. Okay. The single rescue dose can be considered if they are anticipating delivery within a week. That is what is the newer guideline that has come up with. And there is no need for giving a multiple or a repeat courses of antenatal corticosteroids. So definitely this was a very simple question. There's no much to discuss about it. Coming to the very next question, which of the following type is not seen with the twin pregnancy? This is also again a very, very easy question because we start a twin pregnancy with its formation. How is it formed? So definitely this is also an easy question. So this we have discussed n number of times in our discussions, higher discussions. We have discussed multiple gestation. Yes, of course, it's a very important topic. You can expect very important questions, many questions you can expect even in your NEET also. Hypertension, twin pregnancies, and in INICT, they keep on touching upon the same topics. Hypertension, INIC, this one, hypertension with twin pregnancies and your sexual differentiation. Definitely you do have one or another question in it. But this time was little in a simpler way. This was not a very anticipated question here. There are a lot more questions to ask in twins, but they've asked the starting point. It's kind of easier. They usually ask what is the timing of differentiation. Okay. So coming to the question, which of the following type is not seen with twin pregnancy? This was a very, very simple question. See, there is chorionicity which point towards your chorionicity is pointing towards your placenta, number of placenta, and the amnion covering the fetus. Next is monoamniotic. So based on that, you have the twins. So we'll quickly do only upon based upon its twinning process. It is divided into the following types. Okay. One is your chorionicity, that is going to talk about your placental composition. Next is about the mechanism of twinning. Okay, that determines your obstetric risk management as well as the outcome. Now coming to the zygosity, you have the zygosity indicates the no ovum. How many ovum are present? Monozygotic or a dizygotic. When I say monozygotic, a single ovum. Okay, single ovum, 1 in 250. Okay, it's an identical twin, one twin, one sperm, and it cleaves, leading to a other type of pregnancies, other type of twins. Okay. Whereas when I say dizygotic, that means the two ova in a single cycle and they get fertilized. Okay. The monozygotic twins, based on the time of cleavage, it's divided into within 72 hours. It is a DADC, that is dichorionic diamniotic. It is similar to having a dizygotic twin. They are also having a two amnion, two separate sacs with a two separate placenta, that is DADC. Next, coming to if the cleavage occurs between 4 to 8 days of, then it becomes a monochorionic but with the two sacs. They have a single placenta but with the two sacs. If the separation, the cleavage occurs between 8 to 13 days, you have a amniotic membrane also to be used. If it's more than 13 days, it's again a monochorionic monoamniotic. Here the baby itself is fused. That is what is the image is about here. So based on the monozygotic twins, monozygotic single ovum. Based on the time of cleavage, they are divided into DCDA, MCDA, MCMA. Now, so what is this answer? It is monochorionic monoamniotic, that is MCMA, monochorionic diamniotic, DCDA, dichorionic diamniotic, DCMA. Is there something called DCMA? Dichorionic with a single amnion? That does not exist, and this is the answer for this. Coming to the next question. This is a very anticipated question, but this was a little easier question, I have to say. See, it's an 18-year-old girl presented with primary amenorrhea with a normal sexual characteristic. And here are FSHS3 and LHS1 with a XX karyotype. What is the likely diagnosis? So this was your question. This we have whoever has attended the mock exams. I think this also was an easier question for them because we always followed a table and that we to remember. This was a question also that we have asked in a mock exam. If you have a primary amenorrhea, if a patient, a young girl presents with a primary amenorrhea with a well-developed secondary sexual characteristics, breast developed Tranner stage 4 to 5, no pubic hair development with a bilateral inguinal. See, the secondary sexual characteristic, that is, there is a breast development, but there is no pubic hair development. So that fits under your complete androgen insensitivity. Okay. Next is your incomplete. Incomplete also they present with primary amenorrhea with a breast channel development of 4 to 5, no pubic hair, bilateral inguinal hernia, but they also present with clitoromegaly. So that is a little different from that of a complete androgen insensitivity. That makes the difference. Okay. Now coming back to a question. Is it AIS? So it is a primary amenorrhea and she has developed a normal sexual characteristics. With XX karyotype. Okay. So next we have to concentrate on this karyotypes. So the next one you have to remember is your Kalman syndrome. Kalman syndrome also they present with primary amenorrhea with a normal height and hypogonadism, anosmia and color blindness are the triad. Definitely it's not Kalman syndrome. Okay, it's definitely not the gonadal dysgenesis. Gonadal dysgenesis most common is what we have to remember. Gonadal dysgenesis is Turner syndrome. Anything that you have to remember is very first thing that you have to remember for gonadal dysgenesis is your Turner syndrome. There are other syndromes that you have to remember, but the first most important thing is your Turner syndrome. Here comes the answer. Definitely this is not an AIS because it's an XX karyotype. So again, this becomes answer is Mullerian. This is even if you don't know the other options with the table as well as with the certain points that you have to remember in each thing, you could have easily solved this question. If this was a very anticipated topic that every time there is one or another question from this topics, but this time it was a little easier from this topic. Another additional point to remember is about the Asherman syndrome. See, amenorrhea due to intrauterine synechial formation, but here you have to remember is it's secondary to an vigorous uterine curettage in the postpartum period. They present with secondary amenorrhea. It's not a primary amenorrhea. Secondary amenorrhea is a very important thing you have to remember. So anything that first point you have to remember, especially if they say following a postpartum period, that is a very important point pointing towards the Asherman syndrome. Primary amenorrhea and secondary amenorrhea holds a very big important topic in INICET. Please read it for your NEET exams also. It's an important topic again. Coming to the next question. Next question, you have to put yourself in your labor room to answer. It's a very simple question. It was a very, very simple question. Even as an intern, we would have seen this type of cases. It's daily in and out that we encounter this kind of patients. What we could have done for this patient. So it's a simple question. A primary gravida, she was 40 weeks and having labor pain. Now she's in a second stage of labor with a fetal station. Fetal station is at +3 with a small caput, which is at +1. +1 is caput. The caput, the measurement of the size is at +1. In the second stage of labor for the last 2 hours, what is your management of fluid? See, it is almost out, is it not? I have to say very in a simple way to understand. It is seen at the introiters and we have to just deliver her. Okay, they have not mentioned anything about fetal distress, nothing here. Now, how to go about? Put yourself in your labor room and think. Since they have not mentioned anything about the fetal FHS condition, fetal heart rate condition, it is important that we have to put ourselves in a important thing that they have given is she's a primary and second stage is she is in more than 2 hours. That's what they say. So first thing is she's a primary gravida. She's already crossed her 2 hours. So that is one thing. So she's going into a prolonged labor, prolonged second stage. Is it not? So this option is ruled out by this last point. Wait and observe. Yes, some would have marked this wait and observe. We would have not waited because she has already crossed her 2 hours. Last 2 hours, she's already in second stage. With that, she would have not delivered even at that station. We have to put intervene. There is intervention required. Now, what type of intervention? When I say wait and observe, again, we are not going to wait. You've already waited for 2 hours. Now, we are going ahead with the next intervention, either in the form of a vacuum or an outlet. Definitely this nobody would have marked it. Either you would have got confused with your observe, wait and observe, because if you would have not concentrated on this small catch in this question, then you would have marked it as wait and observe. Okay. Next, the answer, what will you do for this? Vacuum is not required. Definitely it's not required. The answer is very straightforward here. You go for an outlet forceps. The answer itself is an outlet forceps. The baby is at the outlet. Is it not? It's a very simple +3 station, just do with an outlet. Yes, what type of it's a very important outlet forceps, low forceps, mid forceps. You have to know at when to apply. You have to know the criteria. Obviously, this is an important question. Fetal head is at or on the perineum. Of course, you apply an outlet forceps. Definitely not a low cavity forceps. There's nothing called a low cavity forceps. It's called low forceps. But where you require rotation of less than 45 degrees is required or more than 45 degrees is required. The station is at or more than +2 station, but not on the pelvic floor. But here you have at the +3 station, so at the pelvic floor. So it's important that the answer should be an outlet. It's a very simple question. Anybody could have answered this question. Which among the following drug is avoided in a hypertensive females in the PPH? The answer is methogen. Methogen it's a contraindication. Definitely you don't give. Carbapenem, oxytocin you give. Carbapenem is contraindicated in bronchial asthmatic. The first thing that you have to remember, first important thing. Prostaglandins is PGE1. When do you give PGE1? When do you do? Yes, this also we have discussed n number of times. Carbapenem, hebamate, which is a contraindicated in asthma suspected amniotic fluid embolism, which is given in a dose of 0.25 mg IM, repeated every 15 to 90 minutes. Maximum up to 8 doses can be given. Misoprostol PGE1, what is the dose that we give? 800 microgram to 1000 you can give. It is contraindicated in ruptured in a previous cesarean section, but of course it is given in a PPH. So PPH is a very important, very important topic that you should never make any mistakes. PPH is a very simple topic, but of the PPH there are so many complicated things to ask, but they've come up with a very simple question. This is a very I think everybody would have answered it right. A primary gravida is O negative and the husband is A positive. She is RH incompatible. A patient has given an anti-D, sorry for the mistake, it's anti-D at 28 weeks of gestation. That is as a part of antepartum prophylaxis that we give. In which condition should we give her an anti-D after delivery? So remember, it's a very typical case of RH negative incompatibility. RH negative pregnancy. So she has received her anti-D at 28 weeks. That means definitely her ICT is negative. So she would have received her anti-D at 28 weeks. And next, when should we give her the next dose? Obviously, after giving an antenatal, it's important that we emphasize on postpartum prophylaxis. How do you give the postpartum prophylaxis? Definitely we send the baby's blood group. If the baby blood group has come positive and DCT positive, will you give her? Or see, the option has become between C and D. If the DCT is negative, when do you give? So DCT is gonna tell you there are two scenarios. Between these two only you should definitely have. We don't give in all cases, no exceptions. That's a wrong answer. Only the baby is D negative. If its baby is also negative, there's no point in giving at all. So definitely these both you would have not marked. The option will be confusion between C and D. Coming to C and D, what does the DCT indicate? DCT indicates whether the maternal antibody that has been formed has crossed and seen in the baby's blood. That's what it means. If it is already seen, if it is DCT positive, there's no point in giving it. If they are DCT negative, okay, then we can give them. So answer is option C. It's a simple question. Which is the appropriate medication to administer to women whose fetus is dead and who is presenting with breast engorgement? Answer is cabergoline is the answer. You give 0.5 milligram is your dose. Other drugs. Metoclopramide is used for breast milk production. It increases the breast milk production, whereas cabergoline is used for breast milk suppression. So it is very important to administer a drug that is the breast milk suppression has to be done immediately, especially if they deliver a dead fetus or following any stillbirth. So it's important that we give. So cabergoline is one is the usually advised drug that we give. This was a little, I think, easier question. Yes, it's little of a basic question. Which among the following is the most important natural estrogen? As we know, it is E2, and you have the conjugated estrogen, and then you have the estradiol, then you have the estrone. As the number suggests, estradiol, estriol, estrone, okay, and conjugated estrogen is an definitely it's an conjugating. You're conjugating estrogen. Definitely, it's not a natural estrogen. Okay. Estrone is seen in your postpartum. I mean, postmenopause. As you say, E2. E2 is important, the most potent. So this is, you have to remember. Estriol and conjugated estrogen. Conjugated estrogen automatically disappears from your most potent natural. So this disappeared. So among these three, estriol is the most important thing you have to remember. This is, and I was also very happy seeing this question. To say I was very happy seeing this question. She is a gravida 2, para 1, living 1 female with 6 weeks of amenorrhea. Sorry for that. They typing error here. The bleeding baby. And with the other sensorium, she has a pain in the abdomen. On perineal examination, there is cervical motion tenderness. Ultrasound, they could see a free fluid with in the right paracolli gutter. What is the most probable diagnosis? Very simple. She's 6 weeks. So your abruptio placenta as well as the placenta previa, both are ruled out. Now you have confusion between the two things. One is a ruptured ectopic pregnancy, missed abortion. They have clear-cut pointed out. They have very clearly pointed out about 6 weeks with cervical motion tenderness and pain abdomen, and with the vitals unstable, that is, she's presenting in shock, clearly pointing towards your ruptured ectopic pregnancy. So it's a very clear-cut clinical scenario that we remember. Discussed a number of times about ectopic pregnancy. And of the advanced things we discussed, I think this was the very simplest, pretty straightforward. They asked the typical word, cervical motion tenderness. What will strike your mind? It's ectopic pregnancy, nothing other than that. We always think 6 weeks with bleeding or she presents with shock. The first differential diagnosis or the first diagnosis itself will be an ectopic pregnancy. Here they've done a scan. If the patient comes with an altered sensorium, with the bleeding, with the presenting of shock, the cervical motion tenderness, all these things, I probably don't take up for a scan, but they have given a question as a scan. But even if they were not given you any scan scenario, doing an ultrasound is not required in this patient. We take the directly for a laparotomy because she's presenting in shock with altered sensorium. The first diagnosis should be an ectopic pregnancy. So very, very straightforward. I think whoever has attended my class, I point out saying that any early pregnancy with amenorrhea, with bleeding, presenting with shock, no doubt take her for a laparotomy. Definitely it's going to be ectopic pregnancy. I don't know if really this question was there. There were some people who have told me this where that this question was seen. What was IUGR criteria or all except? It's a very simple. The answer is you're never talking about a uterine artery PI Doppler for an IUGR where we talk much about an umbilical artery Doppler. Yes, uterine artery PI. We do it in your first trimester for seeing for a preeclampsia. Preeclampsia predisposes to IUGR, but it does not per se as a criteria for an IUGR. So the answer was very simple, and I think this was also discussed n number of times in our exams about what are the parameters, what is the type of EBGR findings that we see. This is how we have read our IUGR. So what is the estimated fetal weight should be less than the 10 percentile and abdominal circumference, and should be is the most important parameter that we use and the most sensitive parameter to detect an IUGR. And all other things we have discussed, and basically they pointed towards your uterine artery Doppler changes here. So you consider, yes, increased high diastolic flow. Yes, uterine artery Doppler is not used as a criteria per se, but you can expect an increased versatility index, Resitin index, and SD ratio in an uterine artery to be increased in an IUGR baby. It doesn't mean that it's a part of a criteria. Okay, ADF, yes. Absent end diastolic is again a criteria. So this is what the Doppler findings. I'm not going in much detail about it. Yes, you have to read about the Doppler findings. Is a very important thing in IUGR. Yes, in IUGR definition, the Doppler changes. Okay, and what are the parameters that is importantly seen in an ultrasound? That is a very important thing that you have to concentrate on. And what time, what period of gestation? For example, when you have ADF, it is necessary that you immediately deliver. But when you see the same scenario changes, REDF, you deliver the baby immediately. There's no point in keeping the baby inside because they will become a IUD, intrauterine death. So these are the certain things that you have to concentrate, touch upon. Okay, please revise IUGR too. I think IUGR they have not asked much in INICT. I don't know if it was really there, but I got from the feedback from the students, they have recalled this as one of the questions. And fetal growth is, they have asked a question on fetal growth, the hormones that is not associated with the fetal growth. And there was a one question on HPV vaccine. I couldn't even actually get that. So these are the topics that I can get. Okay. So that's it for the INICT recall session. I think all the questions were simple, but what is important now is don't think about what has already happened, what the exams are over, is it not? So don't concentrate on what you made mistake, why I made a simple question, I missed that question, it was a very simple answer. Don't think all that. Okay, forget whatever is done is done. Now start preparing for your NEET exams. This recall is not to say that you were wrong in your NICT. This recall is for your upcoming NEET exam. Please concentrate on the topics of given in your INICT and start revising. See, this paper is an example saying that the topics are being repeated. It's the same for any exams. See, whatever you have read, please read it again. Topics, revise it again. That is what is important. I'm not asking you to revise a question. Read the topics that they have asked from your previous question. Okay, that is what is important. All the very best. Keep yourself motivated till your next exams. Don't think about the present, whatever, whether you have done extremely well or your performance was very poor in INICT. Don't put it in your head all those things. You cannot go and change now, but you can definitely bring a change in your NEET exam. Start reading as a topic. All the very best. Thank you.